And I have three excellent panelists in here. I will start out by introducing the panelists, and then we'll talk about data collection and data access, current issues and future challenges, and they will offer their unique perspectives on that particular topic. So I'm going to start out with Makada, who's at the far end of the table. She is a Rubenstein Fellow in Governance at Brookings, and she was, before joining Brookings, she was a senior analyst with the Consumer Financial Protection Bureau. Her research has examined ways to expand equitable access to responsible credit and advance inclusive economic opportunities for low-income communities. As such, she's part of Brookings' Race, Place, and Inclusion initiative, which focuses on improving the economic mobility prospects of young men of color and marginalized communities. And our panel is, and the whole workshop is broadly on health and the social determinants of health. I think Makada has a unique perspective on some part of the social determinants of health that's frequently overlooked, in particular access to financial credits and the financial markets and constraints that come from lack of access that would affect health in the short and in the long run. Our second panelist, Megan Koo. Got it? Okay. She's serves as the Director of Data and Policy Analytics Group at the Centers for Medicare and Medicaid Services, Office of Minority Health. She oversees the development and implementation of initiatives and data analysis to support collaborations to improve data collection, analysis, and reporting of characteristics associated with health disparities. So welcome, Megan. And right next to me is Nines Ponce, who is a professor at the UCLA Fielding School of Public Health and the director of the UCLA Center for Health Policy Research. She's also the principal investigator for the California Health Interview Survey. Her research contributes to the elimination of racial and ethnic and social disparities in health. She's on the board of scientific counselors for the National Center of Health Statistics. She has served on committees for the National Academy of Sciences and the National Quality Forum, where her expertise has focused on setting guidance for health systems in the measurement and use of race and ethnicity and other social determinants of health as tools to monitor health equity. So welcome, everyone. Once again, I'm very glad to have you here. And we will start with just a broad question from your perspective. What are the challenges that you personally and in your research career and your teams have experienced in data collection and data analysis for frequently neglected groups that end up in the other or asterisk categories that we have been discussing quite a lot, in particular in the morning? And I'm going to start with Nines, who has done a lot of primary data research and is the principal investigator of the CHIS. If you could share some of your experience and tell us something in particular that you found challenging or something that you thought was solved well. So we want positive stories as well.
Yes, thank you so much, Emilia. I think you heard a lot about challenges this morning, so I just wanted to maybe end the day with some good stuff, some positive development. I'm going to first start with the looking at gender identity and gender. Since that was the last presentation. So the California Health Interview Survey has been around since 2001. We now are yearly from 11, 12, 13, 14, 15, 16, 17. We're a household probability sample. We survey adults, teens, and children. For children, the parents respond on their behalf, and for teens, we get parental permission. We have, I've been called you're trying to be everything for everyone, so our survey does run long, but I think we're pretty successful. Of course, the challenges are going to be costs because declining response rates with telephone survey. The good news is we're moving to a new mode. But we were one of the first surveys that asked about sexual orientation back in 2001. We did an experiment on gender identity and gender expression, and then from that, like, should it be a 1 question or a 2 question or a 3 question? And then we went to the field. So for example, in 15-16, among adolescents ages 12 to 17, we found that more than 26% of adolescents identify as highly gender nonconforming or as androgynous. So it's pretty high among teens, and so this is, again, like, we would not have uncovered that had we not gotten these questions on gender expression. Before I was as I said, on the supply side, I was always on the complainer side, and I used to work for the organization that Ben over here works for, the Asian Pacific Islander American Health Forum. Again, as John said this morning about, you have an enormous amount of ethnicities for Asian population, an enormous amount of languages. How do you fit this all in a constraint of, say, for the California Health Interview Survey, we aspire to be a 35-minute survey. Of course, it gets longer. How do you put this all in? But somehow we manage, and we do get it we did a study for Robert Wood Johnson. Thank you, Tina. Thank you for doing this. Where we looked at the Asian Pacific Islander population, and there really is, like, after CHIS came on the scene with all the disaggregation of the Asian population, that you saw, if you looked at PubMed, in health, we didn't look at all the other search engines, but that the amount of peer-reviewed publications on specific Asian subgroups went up. I mean, it was like a tsunami effect, if you remember that. So you really, the disaggregation, just, it's not just to sit on the shelf. It really is then to inform the research and the policy. American Indians, Alaska Native. So I think if that's familiar with our survey, we asked for the 5 major OMB racial ethnic categories. But in addition, if you say you're indigenous to the Americas, that then we ask about whether you're enrolled in a tribe, and then whether it's a federal or a state recognized tribe. And then for the multiracial population, if you say you are Navajo and then you're Latino, that's just single, right? So we actually ask if you're Latino and even a single race, of course with more than one race, we have a follow-up question on, you said you were Latino, you said you were Navajo, which one do you identify? First of all, do you identify with one? Because OMB thought it was coercive to go straight into, do you identify? So do you identify, and if you do, then tell us what it is. You could say neither, both, one or the other. And then if you're 2+ races, we also ask that question. And so I think that the lesson is that we try to offer as much flexibility as possible, because it could be based, the racial identification and tabulation could be based on eligibility or kind of access to health services, but it could also be due to discrimination or stigma or acculturation. So there's that flexibility is really important. Oh, speaking of acculturation, we ask country of birth. I don't know if you know, but the country of birth now is no longer going to be in a National Health Interview Survey. I don't know if you know that. I mean, we will be able to get at U.S. versus foreign-born, but not the specific country of birth. So in the California Health Interview Survey, we ask country of birth, but we also ask country of birth of mother and country of birth of father. So we can get at some of this generational domains that have been important in terms of both behavior, navigational skills, and health. We also ask a question on, I think what wasn't said as much today was on immigration citizenship status, which is controversial because, of course, we don't want it in the census because it's what use is this for? But for some surveys, it is very important to get at immigration citizenship status. And for CHIS, we've used it to look at eligibility for public programs, and then more recently, looking at the chilling effects of the potential chilling effects of the final rule of public charge on food, healthcare, on access to food, healthcare, and affordable housing, and how that affects immigrants as well as immigrant families. So I think that there's we've been in this business since 2001, so we're not out of business, which means that you can be as granular as possible. We also do oversamples because granularity is great. You can collect, but if you don't have enough, then it just sort of sits there. But I think that it's the power of community stakeholders and engagement that Sela had mentioned. There's a lot of support for us, and then again, this mix, the paying, this model of public, private, federal, state, local, has been a challenge. I guess that's my challenge, is raising the money, but at the same time, I think it's what makes the survey work. So.
Great. Megan.
So I think for a federal agency, one of the biggest challenges is the ability to collect the data in compliance with the law. We have to write proposed rule, put in the requirements, ask for public comments. Sometimes people agree with us, sometimes people don't agree with us. And if we have an overwhelming, non-consensus, then we can't really implement that in the final rule. So it takes a lot of time to do that and to make sure that we follow the letter of the law. So I think, and then in terms of, for the Medicaid program, we have to work with the states, and we have 51 Medicaid programs along with the territories. And, one Medicaid program is one Medicaid program. So it's very challenges to handle, and to work with all the states to make sure that all states report to us the same standardized data. However, in terms of the good news is that we're very, patient and persistent. So we continue to work at trying to improve the data collection. So the, under the OMB standard, 1997 standard, we have the 5 categories plus other. But in the Affordable Care Act, Section 4302 disaggregate the data. So in terms of Hispanic, I believe it gets broken down to an additional 5 categories. And then for Asian, it's broken down to 7 categories. And then for Native Hawaiian and other Pacific Islander, I think we got broken down to 4 additional categories. So it takes a while, from 1997 to 2010, but we're slowly making our way there. So one of the good news we did, at least working with CMS as a whole, our Office of Minority Health, in the post-acute care settings, the skilled nursing facilities, inpatient long-term care hospitals, what we're trying to do is trying to collect race and ethnicity data for these long-term care or post-acute care settings, so then we can identify areas of disparities. What are the beneficiary who's transitioning into post-acute care setting, what are their needs? So in addition to collecting race and ethnicity at the disaggregated level, we also asked for social isolations, health literacy, interpretive services, preferred language, and transportation. We're hoping that these additional informations will give us, a better sense of what's going on to the bennies who are being transferred to the post-acute care settings. Additionally, on the Medicaid side, we added to the marketplace enrollment form the collections of race and ethnicity at the disaggregated level. However, not all states have all of them listed out. Some of them are still using the 1997 OMB standards, but to the extent that we are able to get the data back. But unfortunately, there's still smaller populations for some of the disaggregated, data that we're looking at. And I think I was looking at Native Hawaiian, other Pacific Islander for the state of New Hampshire, and there were definitely not sufficient data. So what do we get? We get NSD. So, and then some of the other states, they're just so small that all we got is 0%. And then, of course, there's the rule that we can't, publish anything that is less than 11 based on the HIPAA law. So there are definitely challenges out there, but we're working on it and trying to improve our data collections in order for us to identify and target areas for improvement for disparity issues.
Great. I think there should be no convincing that financial well-being and public health outcomes are inextricably linked to each other. I was just looking at the American Psychological Association study on stress for Americans, and Gen Zs, as well as all adults, are reporting that money and work stresses outweigh health concerns. So when we think about data disaggregation and public health conversations, we cannot silo financial well-being. And so I'll pick up on some of the issues or strains that you just addressed. I came from the CFPB, and there we had the unique opportunity, a once-in-a-lifetime opportunity, to update and enhance the Home Mortgage Disclosure Act. And this is, data that is reported at a person level, looking at most, not all, of the mortgage transactions that occur in this country. And that's a pretty critical data set. One, it's unique in that it's administrative, so it's very different to the other sort of crucial data sets that we rely on to measure and monitor financial well-being. I would say SIP, PSID, SCF, which is Survey of Consumer Financial Finances by the Federal Reserve Board, all surveys, all probability-based. So we had this really unique opportunity to enhance and strengthen HMDA reporting. And, we fielded thousands of questions and comments about this question on data disaggregation, because, of course, HMDA lagged all of the wonderful public health data sets on disaggregating race and ethnicity. Both comments and research inform us about this very diverse, experience that, for example, Asian Americans, have, and sort of would lead to, I think, misleading stories about well-being and great mortgage experiences. But in answering your questions around opportunities and challenges, my goodness, they abound. We had to contend with, well, how far should we disaggregate? How do we align our levels of disaggregation with other public data sets that are already available? And so it was sort of easy to disaggregate Asian Americans, follow standard practice, as well as Hispanics, but nowhere was there a conversation around disaggregating the African American race code. Right? So when you think about the African American population in this country, it's bifurcated around, trifurcated. You have African immigrants, Caribbean immigrants, which I'm one of, and U.S. Black, well, multi-generational. And if we don't understand how these nuanced differences among these populations expose, some to persistent instability and actually have better outcomes that are on par or exceed that of non-Hispanic whites, we're missing a lot of important information and experiences and realities about African Americans. So challenge, hopefully we'll hear, now that I'm on the other side, become a complainer around, advocating for disaggregating, the Black or African American field. Then separately, there's been very little conversation around geography disaggregation. For Native American populations, this is a critical issue. So when we think about lending coverage, we're really we're doing a really good job at covering metro areas as we measure it and sort of cover by census tracts. When we talk about people or populations that are hyper exposed to poor health outcomes, poor housing outcomes, we're really talking about people who are rural and hyper spatially isolated Native Americans. HMDA data, in our experience, it doesn't do much good to disaggregate below that rate, that code. To tell us, differences among tribes doesn't really change, aggregate distributions of poverty or employment. What's really going to be helpful is, maybe figuring out how we can, maybe do special studies that are match GIS or geocoded data that are contiguous with reservation land. The outcomes of Native American communities depend largely on where they live. So if we can't disaggregate and separate reservation land from urban Native Americans from fee simple land, for example, which matters a lot in the credit space, we are missing opportunities to better serve these communities. And then there's one other challenge or hiccup with disaggregated data. It's how it's collected, right? So we're rushing to compliance, and what we don't, stop and consider, especially in the credit space, is how do we impute missing data? So a lot of times, well, not even a lot of times, in the official guidance, we instruct financial institutions, if an applicant, an in-person applicant, does not report or does not want to, report their race, ethnicity, regardless of, the subgroups, you can infer their race based on a visual observation or by their surname. Now, we've struggled, a ton with BISG, with, Bayesian information surname geocoding, and that does a really good job of distinguishing between Hispanics and Asians. It's really difficult for African Americans and whites. But when you think about, how people identify with their race and culture as well, and how that disconnects or is disjointed from how other people observe that, you're really thinking about mismeasurement issues that we're not, that's not part of these global conversations, but we should, hopefully incorporate those.
Great, thank you. I actually would like to follow up right where you left, and my next question is about how we do the surveys and the data collection. So you can do it in person, you can do it on the phone, you can do it on the web. And in your experience, are we switching? Is there a transition from in-person to phone? Is the phone now not really a good way to reach people because they don't pick up? Is the web what's coming next? What are the challenges there, and where is the field going? And we can start with Ines again.
Well, we're leaving phone. I think the Pew folks left, but I'm sure they would report that the phone is not the way to go at this point. In person would be the best way, but it's expensive if you're trying to, get the whole state, in person. It's more expensive. There's a resurgence of mail. Actually, before we never really opened our mail, and now we open our mail. We don't answer the phone, but we open our mail. Apparently, so I didn't go to the APOR meeting, but that was so they're all the survey methodologists looking like what's the next best thing. But the random digit dial telephone approach is not going to work. However, I think we did an experiment. We did before we decided to switch from telephone to address-based sampling and push to web. And address-based sampling push to web performed better. It's also cheaper, but the folks left behind were the limited English proficient populations. So they do need the they do need the phone. So we are doing an accommodation for phone for that group. But I think I neglected to say we do the survey in English, Spanish, Cantonese, Mandarin, Korean, Vietnamese, and Tagalog. So it's so then what was raised to us after, of course, we went through IRB was you can't just have the web in language because the literacy in those language, they may speak it, but the literacy may not be that great. And so we should have some kind of audio component, which again kind of raises costs. But I think in person is the best. I do agree with special. I'm glad please complain because I'm writing ideas because we're always trying to total continuous quality improvement. Special surveys may be the way to get at populations that you can't get in a probability-based sample. So I talked about the Native Hawaiian, other Pacific Islanders. I also think I was going to say something else. So I'll let the others while I think about your specific question.
So I think from a CMS perspective, we have to take into consideration the beneficiary age level that we serve, so 65 to 85 and older. And so how many of these people are, technology savvy that actually log onto a website or fill out a survey, even check out their email, right? Maybe the 65 around there, or a little bit older where they have their kids, their grandchildren to help them out. And even, as we work to update the technology at CMS, we recently upgraded our Medicare.gov account for, Medicare beneficiary to log into and be able to see all of their claims and transaction in one place. We still have to take into consideration of how many of our beneficiaries are actually going to be able to do that. And we sort of like try to track and see how many new users we have in based on the populations that we currently serve, which is almost 40 million people. So I think as we collect data, we have to take that into consideration, especially the older population who doesn't speak English well. And they live by themselves, and they live in a community where they're so used to everyone around them speak their native language that nobody really has a need to speak English. So we just have to take that into consideration as we survey for information.
So I think the question is different when it comes to financial services, especially from the regulator perspective. Regulation moves really slow. I don't know if anybody of you noticed, but between 1975 and 2015, nothing had been updated, with HMDA. In the meantime, so much has shifted in the market, and so much has shifted in our demographics. And so the challenge is, how should regulatory data sets, these administrative data sets, keep pace with the population changes? Because I think we're running up against a time clock that is creating a bigger and bigger gap. And I think it's, we have to really consider, especially in the financial services space, how people are moving from in-person interactions to an online experience almost exclusively. And so if you're thinking about those GMI boxes, which we were so, happy and so excited about finally getting on the table, who's filling in those data? How prevalent are imputation methods now in those data fields? And then what does that mean when it comes to measurement error rates? And so I think it's not necessarily a question of how to collect the data, but what are the risks associated with the validity and reliability of these statistics? And maybe there's an opportunity to have these data sets, I think, be updated at maybe a shorter frequency, guided by survey data perhaps. I think it's a real challenge from our world.
This actually, Ines, did you want to finish your comments, or?
It was actually not on the mode, but on imputation. So, but do you want me to talk about imputation? So I think back in 2007, I was on this National Academy of Medicine, IOM committee, and at that time, I believe it was 70% of race was imputed in in claims data, in medical claims data, and in Medicare data. I just want to make sure I have my fact check here. I'm not sure how much it's budged. A lot of it is imputed by a surname. It's improved by marriage certificates. I actually suggested driver's licenses at some point, but not voter registration, because then you're not going to get an immigrant. So the imputation piece is really a big piece, as well as the weighting piece for surveys. The weighting piece is important, especially if the control totals, and this was alluded this morning, if the control totals, if it's the ACS with all the kind of measurement error in the ACS, or the potential moving forward after 5 years on this adding noise to the data, that's also like another threat for us. So I think, and then what goes into this, but I'm always looking at the bright side. So and then machine learning and AI and all that. So it's still people behind who makes those assumptions. And so you do want to get the best and the brightest that understand the cultural context to be in those decision making, because it's all assumptions. So what assumptions get put in? So not look at it as this black box of we don't have any power doing this, but it's really it's an opportunity, because it's again, like from the supply side, I want to have machine learning do all the writing, and it takes a long time. Tara, who's now at National Academy, but also used to work for us, it's takes a long time to deal with the, other specify category. And then the imputations, like what goes into the imputations. So it's an opportunity. So I think if we understand but we have to first understand what the real threats are, and then how the methodology with advocacy groups, the cultural component folks, they have to be together in the room so that it really does get at a more, I don't want to say precise, but a measure that has higher fidelity in representing the population that we're trying to depict.
Thank you. And to follow up on that, especially with the imputation that was raised, but also going back to something that came up in the morning about the way different data are collected and how some categories may be reported in some ways in some data sources, but in other ways in other data sources, the numerator versus denominator issue. I'm wondering what if you have ever tried to address this issue, or at least quantify how bad it might be. So one way to do it, if I can think of, is you have data on the same people from two different sources, and then in one source they say they're biracial, and in another source they say they're, say, African American, right? And so how often does this discrepancy happen? And is it even possible in your experience? Because, well, I work with Swedish data, and there everybody has a unique ID which is scrambled, and you cannot really trace it to the person. And you can look at any kind of data set which has the same unique IDs. So I know how they're classified when they go to the doctor, and how they're classified when they go to the tax authority, and how they're classified on their birth record. So then I can tell, well, this person is, African American, African here, and then they're Sami there, and then they're mixed race somewhere else. But that cannot be done here with most data, unless you have really detailed access with some really, special data sets. But in your experience, do you have a sense of how frequently that is a problem? Has anyone quantified this? Have you experienced this in your own work?
I would just say in my work, what we do is decide that if you pick, two race identity categories, if one of those includes a minority, so let's say you pick white and then Hispanic or, Cuban, you're defaulted to the minority group. Of course, that muddies the water, but it's just the simplest way, and that's the conventional way that we've done it. And that, of course, like I said, just really adds to a ton of mismeasurement, but it's the best that we can do for now. I don't see that changing in the future, though.
Yeah. So there's a distinction between self-identification and the tabulation decisions that are made by survey leaders. On self-identification, which could be fluid, and context-driven. I have not analyzed it, but now this conference is great because I have all these research ideas now, because I think our data could answer some of these questions. We have a discrimination module in the California Health Interview Survey. It's not all the time, and it's not the full set. But there were some years where we did put it in. Again, we experimented on A versus B. Nancy Krieger's versus David Williams. We were all working together, and whether you should ask about experience of discrimination and focus it immediately because of your race ethnicity, or ask a lot of different dimensions, with race ethnicity being one of them. But we ask about race ethnicity pretty early in the survey, and then later on we infused a discrimination module and asked race ethnicity again. So there were individuals that actually, even within one survey, changed their reporting of race ethnicity. This is a paper that I had this idea of doing. Because we prime them on the next questions are going to be asked about how unfairly treated you are. So it primes the person to be race-focused and then could change. So the hypothesis then perhaps is that, particularly for those who did not identify as a minority or who had multiple race identifications, and one of them being a minority, if they then tended to identify more with that minority group. So I think just if even one survey within 1 40-minute space, that there's that change, then as we know that it changes, particularly with code switchers, it changes of how you identify at work, at school, how in the life course, as a young adult and as an older adult. But I think what you were alluding to, Amelia, is where it's a challenge for us is for us who understand that linkage of data makes the data powerful, right? Is it almost time? Okay. So you want to link the EEOC data. You want to link the housing data with social determinants of health. Link housing with food, with putting it all together, and then since we don't collect Social Security number, everything has to be probabilistic. So it's probabilistic matching. So that's where there's going to be, if somebody reports something differently in another data set, then the probabilistic matching is going to have more errors. But we already know that because it's probabilistic.
So we used to get our data, race and ethnicity data, from the Social Security Administration. However, as of 1990, they stopped collecting race and ethnicity data on the birth certificate. So by the year 2055, we're probably not going to have any race and ethnicity disparity issue because you have no idea what the race and ethnicity is. So in terms for the Medicare beneficiary that we have Social Security number for, so we have the chronic condition data warehouse that some of you may have access to for your researches, and we do some race imputation in the CCW for a flag there, but we are constantly looking for ways to improve our data collections, especially on race and ethnicity, in working with our other federal partners in terms of data linkage to make sure that, to be as consistent as possible.
Can I just add that I think this conversation around limited English proficiency, this LEP, might be an opportunity in the financial services space for those who are collecting research ideas or want to join the complaining group. As we lose, I think, reliability in self-reporting, self-identification, especially as we're moving into this sort of online anonymous application world, people are more, I think they're more apt to report their language preference more reliably than they would their race, ethnicity, and that's probably not as I think subject to manipulation or influence. So, for example, there are a lot of Middle Eastern people who identify as white and will check that box, but we'll probably get more information about them if we ask about their language of preference, for example. So in early 2020, a new mortgage application that is going to roll out universally, and we have one check the box on, do you prefer a language other than English? And we don't ask any other information. That's a limitation, but there's also an opportunity to advocate for, I think, some further work and further rule expansion around collecting that data that I think ultimately will be the backdrop or the backstop to providing more reliability and validity to the race ethnicity fields that we've expanded.
So can I ask, do you see a big difference in prefer writing language versus spoken language?
I don't know. I'm not sure, but that is a good question.
It depends on what your purpose is.
No, you're absolutely right. What we did see were lenders, consumers complaining about being marketed to in one language. And so they were great. I understand the terms. And then all of the subsequent communications from the lender would come in English. And so they would, miss payments or not understand that the introductory APR was expiring. And of course, that would lead them to default. So it's, this issue of limited English proficiency is really critical, and it matters, in a bunch of domains beyond just access to credit.
I would endorse spoken, just because written, could be, you're going to like miss out all the Tagalog speakers who can't read Tagalog because it's so multisyllabic and so hard to read. Well, okay, at least you'd miss me. But it's, I think that's an excellent point about language because I have analyzed Medi-Cal, Medicaid data, and the primary language field is much cleaner, more populated, and gets at less missing. And it does get at some of the cultural contexts and racial ethnic differences than the race language.
Okay, thank you. I will open it now to the audience for questions to our panelists. Yeah, Randy?
Hi. I have a question for sort of Megan and Makeda. It seems like a no-brainer to me that, CMS and HMDA data should contain information on race and ethnicity. It seems like that would be information that they would want to know. What's the sort of the rationale why it doesn't exist in the first place there? Is it sort of this idea that, well, had we known people's race and ethnicity, we, decline their mortgage lending, because that happened anyway. So why not just collect it? And same thing with the regard. Is there a rationale? I guess my question really is leading to, it sounds like it might be changing because, or is it changing? Because it sounds like 70% imputation is horrible. And so I guess I just want to get what your sense of that is.
Like I said, we used to get our data from Social Security Administration, so it existed before, and so as time changes and we just kind of have to work with what we have. We are looking at other means to continue to collect the data in order to make sure that we capture the necessary information. So it's, unfortunately, sometimes, rules and regulation gets in the way and changes, and sometimes people think they're making improvements, but they don't take into consideration across the board of the impact and the consequences.
So the simple answer is because it's always done that way. 1975, Civil Rights Act, and so it took a lot of research and advocacy to get regulators to listen and understand that and this was primarily driven by Asian American research and advocates, that the experience for Japanese and Chinese is not the same for Taiwanese and Indonesian people. And place matters a whole lot too. Where you live determines your outcomes. So, and I think that's what moved the conversation from, these aggregate reporting categories to the subpopulation. But I think, we grappled a lot with two topics we haven't touched here on the panel: privacy. The more data points we release, the more, there's a risk of re-identifying people. And that was, a real concern for us as a regulator. And then the other piece is, it's pretty simple to sit on the side of the complainer and say what I want. But coming from the regulator perspective, we have to contend with, balancing burden. A lot of our institutions, small, medium-sized businesses, or even small, nonprofits, organizations that don't have the capacity, to report and to comply with increasing data burdens. And so on the one hand, even though evidence shows us that this is beneficial and, really, helpful and moves the conversation, there are true hurdles from a regulatory perspective that slows down the debate, and definitely slows down, the output. And some of that is even, codified in law. In order to put out a new rule, all of the prudential regulators have to consider the SBREFA Act, which makes you slow down and think about how many businesses out there, how many consumers, what's the potential impact, and therefore the burden. So there are lots of hurdles that are invisible to researchers and advocates that are not, invisible or are not, immediately movable from the policymaker perspective. And privacy is, looming large, particularly as we push towards data disaggregation.
Any other questions? Nope. I guess everything is clear.
So
Or not.
Amelia, before we end, I think going back to our earlier conversation this morning about, limited data on the API populations, in the AIAN populations, I do want to highlight 3 products that our office did. So in August of 2017, we issued a data highlight/research report on understanding the health needs of diverse group of Asian and Native Hawaiian and other Pacific Islander for the Medicare beneficiary. Annually, we have been working on a Part C and D performance data stratified report by race, ethnicity, and gender, which includes comparing AIN, API, Black, and Hispanics to the non-Hispanic white populations. And for those of you who don't like to read, this is a great report because it's filled with graphs, like 200 pages of graphs. We also, last year, we issued a rural-urban differences report looking at, in this case, unfortunately, due to limited data, we mainly look at API, Black, and Hispanic compared to white, who, based on their clinical experience and patient care experiences in rural and urban areas. And lastly, there was 4. And lastly, we have what we call a mapping Medicare disparities tool. If no one has ever taken a look at that, I would definitely recommend to take a look at it. Is at go.cms.gov/MMD. It is an interactive web-based tool that you can actually search by race and ethnicity that highlights areas of disparities based on chronic conditions, sex, age, and gender by year, by county profile, states, and at the national level.
I think, oh, sorry, what is this? Oh, okay. And I'm not going to talk about our products, but so it's data disaggregation, it's collection, it's reporting, and then it's access. So this is related to the privacy and access tension. I think it's really important that that the conversation is like, so you do all this effort for collection, and with that perhaps oversampling. And then you make as flexible as possible decisions on tabulation for the users, so you're not over-prescribing, or you're prescribing like you have to do it this way. So an example in California is our Department of Finance automatically has a Latino trumps all rule, which is if you're Latino and anything else, whether single or 2+ races or other, that you're Latino. And that doesn't affect a lot of the bigger groups, but it does affect American Indians, Alaska Natives a lot. So what is presented is non-Latino, single race, American Indian, Alaska Native in all the presentations in the reports. So I think that there's this reporting based on tabulation rules that survey leaders or policy or decision makers like Department of Finance do. And then the access piece, I really liked the speakers who talked about the privileging of access to data. And so the groups where you do all, so suppose you get to the point where you made all the effort to do this, but then it still isn't releasable in public use files. So then the groups that are, that you want insights on the rarest groups by geography or by socio-demographic domain, then you have to either, there's hurdles to get at the restricted data, because that this group collects it. That NCHS collects. I mean, back when I was an advocate in 1992, we knew that they collected data on Asian subgroups, but they never released it. So, again, having this barriers to entry, having the highest cost barriers to entry to the groups that we have the least insights is not. That's what's got to be fixed as well. So we got to think about that, and that could be in terms of perhaps differential pricing, or for these barriers to entry. We just finished a study working with the RDC at UCLA, where we looked at 7 federal surveys from NCHS, also from CMS. We looked at the MCBS as well. And we looked at also data from IPSR. And it was just very it was long. I could have done a survey during the time that we waited to get access to some of the data sets, and it was on American Indians, Alaska Natives, and the reason why we had to go to the RDC is that first we thought we could just use public use files, but we couldn't use public use files to get any insights on these tabulations that looking at different tabulations of Latino single race, non-Latino single race, and then more than one race, American Indian, Alaska Native, and then looking at different health indicators. We couldn't do it. It was just impossible to do. So we had to use the RDC, which created a barrier again. I mean, so we knew how to navigate, and this was our specific study, but think about like all the groups that want insights on particular populations, so high cost. And then even when you got to the restricted files, it was really just difficult to figure out the coding rules because there was still aggregation going on. So I just think there are a lot of issues to think about, but maybe to be systematic in looking at it again from, there's a collection issue, there's a reporting issue, there's a tabulation decision issue, and then there's an access issue, and then how that affects each of the different groups.
Thank you, Nines. I think the last part about the access we haven't really touched upon, and I think it's crucial in particular for if you want to gain insights into what is going on. Without the access, even if we do all the collection in the world, we won't be able to get any insights. So, Sila, last question, and then we'll conclude.
Thank you. I did just want to add to Ninez's last point about the process with data collection. And I would like to add, I think what's also important is making sure that we have the identifiers as part of your your questionnaire or data collection instrument. Because without the question on race and opportunity to race alone, race in combination, you're just not going to get that information. And the explanation that, oh, the cases are too small, guess what? The truth is, you don't have any of that information. So there are questionnaires, there are national surveys that are very clear. HRS, PSID, white, black, Hispanic. You're not going to get any information on Asians out of the HRS, right? And that is because there isn't the an identifier or a decision made to collect data on these groups and population. And the other comment I had is, the concern, and I think this applies more with the surveys, is coverage with the modes that you are using in ensuring that you are reaching across the state, as opposed to, and taking consideration that there may be areas that may not have the wideband or the broadband access to internet, so they would not be able to participate in your survey. Likewise with the telephone line. And Makeda, I think, mentioned that in one of the administrative surveys, the collection of data on race has been dropped, so you wouldn't be able to know a person's race. And if so, my concern and the problem I have with that decision is that they would not then be in compliance with the revised OMB, because the revised OMB is mandated for federal agencies across the federal government. So I'm wondering if there's a reason, or you could explain the reason behind that decision.
Well, let me clarify. I don't think I said dropped. What I said was there's a gap that's emerging in terms of how this race ethnicity data is being reported or collected. So as people move to an online experience, applicants move to an online experience, we're not really, if they choose not to fill in either of the race boxes or ethnicity boxes, financial institutions, per regulatory guidance, are instructed to impute that information, right? So if it's an in-person, then you can, observe, or you can use their surname. And so my point is there's going to be, a disconnect as, 99% of prospective applicants go online for mortgages. But one of the points that you did raise made me think about this geographic disconnect. Right, so for Native American populations, I cannot stress enough how much of a blind spot we have, regardless of what domain we evaluate them in. Particularly in the credit space, how do you distinguish the experiences or the differences between Native Americans who live in urban areas versus those that live on reservation? And I think when we even if we want to capture access to financial services on or off reservation, the best we can do is make rough approximations with GIS technology. I can't tell you how many times I've done this rough matching through GIS, and it's ridiculous. Not at the point in time where we are. So to move the conversation, we need to advocate, because there's no data to present an empirical case around the importance of thinking differently about what kind of data disaggregation conversation should be considered, and it's not just race alone.
Thank you very much to the panelists.
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.